From Microbe TV, this is TWiP, This Week in Parasitism, episode 257, recorded on April 11, 2025. I'm Vincent Racaniello. You're listening to the podcast all about parasites. Joining me today from New York, Daniel Griffin.
Hello, everyone.
And today's Friday, so we have some STD on your tie.
Yes, but unfortunately, everyone at the CDC and the STI division, except for one lone person, was fired. So we're never going to know what the bow tie actually has on it.
Is it true? They're all fired?
Apparently, everybody save one, I was told by an anonymous source. Wow. It's just, it's this attack on science is just really over the top. Right now, and I think we've talked about it, previously, we are at the highest rate of syphilis, like in modern history in the U.S. We couldn't even keep up with enough penicillin in the clinic. And now we're just, if you don't look, if you don't test, if you get rid of your entire sexually transmitted infection division, there's not a problem, or at least not a problem that everyone will be aware of. So, yeah, this is devastating. But no, it is the clap, the famous gonorrhea, which was actually, maybe this is kind of the same idea. It was cured by taking a Bible and then clapping it closed. And patients would never come back with a return of symptoms after that.
Also joining us from Glasgow, Scotland, Christina Naula.
Hello, good evening. And I was just going ooh, painful.
Right? Pretty much it's like you're cured. And if you have any recurrence of symptoms, you come and let me know. And they just never come back. I don't know what that could be.
Yeah.
Neisseria gonorrhea, right?
Yes.
Very good. Good name, Neisseria. All right, Daniel. We're here to solve last case from 255. Tell us what we have.
Okay, I'm excited. I've got my tea and my water. My voice might be a little raspy. I apologize, but I was intubated a little bit earlier today, but all better now. And this is the case of a man who was on eculizumab. So what is eculizumab? So remember, it's a mAb at the end, so monoclonal antibody, and this is a humanized monoclonal antibody that targets complement protein C5, which serves as a terminal complement inhibitor. Actually, so characteristic that we're talking about Neisseria, right? Because people with issues with terminal complement inhibitors are actually at higher risk of Neisserial infections. So just sort of a little small world. But this gentleman was being seen by his doctor, and comes in this time to see the doctor that's managing the eculizumab with a problem with left arm swelling. Now, this all takes place on the island of Borneo, and then we're in the northern portion. He's being managed by a doctor in the Malaysian city of Kucheng. Now, the doctor caring for this man, I shared last time, is married to an infectious disease expert, and she raises concerns that this might be due to a parasitic disease. She is told by her husband that the disease of which she is thinking is not present in the region. Don't worry about that. Nothing to see here. But she is not swayed and admits this gentleman. He ends up in the hospital. They do nightly blood smears looking for this possible parasite. They're negative. But then she actually gets access to a rapid immunochromatographic dipstick test that actually is positive. So a little more investigation. Turns out that this gentleman lives in a community not right there in Kuching, but outside the city. And actually, they go and they investigate. I was saying this is like a House episode, right? They send the people out and they go to the village. And actually, it turns out there are others in this village with limb swelling issues. They do some antigen testing. Turns out a number of them are the people with the limb swelling are positive as well. So putting it all together. Now, really interesting. She relates that this doctor who's telling me the story relates that she did not have access to the anti-parasitic that she ideally wanted to use. So instead, she puts him on an antibiotic for 4 weeks. And the arm improves. And my hint was that for those tuning in for the first time, was that this is not Wuchereria bancrofti.
All right. Christina, can you take that first one?
I can. Paul writes, returning book winner, diagnosis, lymphatic filariasis due to Brugia Malayi. The differential diagnosis of unilateral arm swelling would include local processes affecting the soft tissues of the arm, such as bacterial cellulitis or an injury. Processes which obstruct venous return, such as deep vein thrombosis or external compression of the brachial or subclavian vein, and processes which impede lymphatic drainage of the limb, such as filariasis. The finding of other cases in the village, which has limited mosquito control, supports a vector-borne infection, such as that caused by Brugia Malayi. There are rapid antigen tests for this parasite. These roundworts carry the bacteria Wolbachia, an endosymbiont, and the nematode requires the bacteria for survival, an obligate symbiotic relationship. Treating the patient with the bacterial antibiotic doxycycline kills the bacteria and also eliminates the nematode, hence the patient's response to the non-antiparasitic drug. Thanks for a very interesting case and the microbiology vocabulary review.
What vocabulary review does Dr. Paul refer to? Do you know?
Yeah, what is that? Do you know what Dr. Paul might be referring to?
Maybe the last episode we had some vocabulary. I don't know.
Yep.
Daniel, can you take the next one?
Sure. Jay writes, Dear trypanosomes, language is rich with meaning, and medical terminology is no exception. Oh, I think I was doing when I talked about stuff, I was putting in the definitions. Because what was it like when you treat someone with a antimicrobial and you see how well they respond? We call it empirical trials, but there's all kinds of fancy words for that. But anyway, okay, so language is rich with meaning and medical terminology is no exception. The name of the location where this case occurred was a clue. Prior to 1963, Malaysia was also called Malaya.
That's so cool. I didn't know that.
The man in this case and others in his village have lymphatic filariasis. L.F. Otto Wucherer and Joseph Bancrofti were among the scientists who first identified one of the causes of lymphatic filariasis in the late 19th century. In the 1920s, a nematode was named after the two of them, Wuchereria bancrofti. In 1927, working in what was then Malaya, Stefan Lambert Brugge, another name there, identified another species that caused lymphatic filariasis. Several decades later, in 1960, the current name of this species was adopted, Brugia malayi, referencing the scientist Brugge and the location Malaya. Humans are the only host for Wuchereria bancrofti, so Mass Drug Administration, MDA programs have been successful at breaking the chain of infection in many parts of the world. Not so with the Brugia species. Brugia can infect human and several other animals. There have been MDA, Mass Drug Administration efforts in Malaysia, but lymphatic filariasis due to Brugia species has persisted and even increased. It's possible there have been limited pockets of success in these eradication efforts. Perhaps that is why the husband of this astute physician in this case did not think the cause was Brugia. The antibiotic this man was given was doxycycline, targeting Wolbachia gram-negative bacteria that live within all species of Brugia, and Wuchereria as an endosymbiont. The worms need the Wolbachia bacteria for survival. Kill off the Wolbachia with doxycycline, and the host species, Brugia or Wuchereria, will also die off. This gentleman was fortunate to have such a thoughtful and persistent physician caring for him. We are told his swelling improved with treatment. It can be irreversible unless caught early. Thank you for another excellent case, and this is from Jay.
I would say he was lucky to have the guy married to an infectious disease specialist.
Well, remember the infectious disease doctor was saying, oh, and don't even worry about that. So.
Well, the guy who was taking care of him said, we don't have that disease around here. And his wife said, oh, I'm not so sure about that. So.
Yeah, yep. So he was lucky that yeah.
Let's see. So Jay, I don't know if Jay has won a book. I know Paul has won a book. So let's put Jay in for the
You can
drawing.
always let us know, Jay. If you won one, let us know.
Ben, I think I will put Ben. So this is my read. Ben writes, the patient had lymphatic filariasis. The causative agent was likely Brugia malayi. Brugia timuri is also a possibility. It is not supposed to be on Borneo, but a pathogen outside its reported geographic range was mentioned. The treatment with antibiotics for a parasite narrowed the options dramatically. Many nematodes need symbiotic Wolbachia bacteria to live. Google and the CDC webpage took me the rest of the way. Drugs for the patient's neighbors, along with mosquito control, may be useful. In my day job, I am part of a team trying to fight Anopheles mosquitoes with Wolbachia. On the floor above us, they are trying to make better Wolbachia-killing drugs to fight nematodes. Counterintuitively, we get along well. Sincerely, Ben in Liverpool. Back to you, Christina.
Jason writes, greeting TWiP hosts. In episode 255's case of the swollen arm in Indonesia, the patient appears to have been infected with the Filarial nematode Brugia malayi. The successful treatment of the patient with a 4-week course of an unnamed antibiotic is consistent with one of the treatment options for Brugia malayi, extended tetracycline therapy to eradicate the nematodes, Wolbachia bacteria endosymbiont. Eliminating Wolbachia interferes with further development of microfilaria, not only putting a stop to the nematode's life cycle, but also preventing further transmission. Warm regards from Jason.
Daniel.
Yu writes, hi TWiP team. My name is Yu, and I am a first-year PhD student who really enjoys listening to the suite of This Week In podcasts. My guess about what is afflicting these people is Onchocerca volvulus, the causative agent of river blindness. It is typically only found in Africa, Yemen, and some places in South America, which would explain the husband's comments about the pathogen not being present in Borneo. However, the Similium black fly vector for the disease does live in Malaysia. Additionally, onchocerciasis can be associated with limb swelling, cannot be detected using blood smears, but a urine dipstick test does exist for this condition. The endosymbiont Wolbachia is associated with Onchocerca volvulus, and doxycycline can be used to target the bacteria, which may result in the killing of the parasite outright. As a result, it seems like this parasite would fit all the evidence from the description. Thanks so much. Keep up the good work. You.
It sounds good, except if the fly vector is there, what good does it do unless the parasite's there too?
Well, there's loads and loads of different black flies all over the world. You know, black flies are everywhere.
Yeah.
So maybe it's not the right kind. Or maybe it just never got there. You know, like the schistosoma mansoni. Maybe did not travel there with somebody.
Yeah. All right. Michelle Alexander from the First Vienna Parasitology Passion Club. Right. Dear Filariophiles. Patient exhibits typical signs of lymphatic filariasis. While there are several species of filarial nematodes which can present in this way, most of them, including Onchocerca, Loa loa, and Manzanella species, are not endemic in Southeast Asia. Dirofilaria immitis mostly causes disease in canines and presents as an aberrant lesion in humans from time to time. Excluding Wuchereria, the remaining species of filaria in this part of the world are Brugia malayi and Brugia timuri. Since B. timori has never been described outside a narrow geographical range in southern Indonesia, infection with B. malayi is the likely explanation for the symptoms. It can also be diagnosed via dipstick test. While DEC and albendazole combination therapy is generally effective, it can be enhanced by the addition of ivermectin or by targeting Wolbachia by giving doxycycline. Treating the infection generally does not improve lymphedema, which is managed by compression, wound care, and sometimes surgical intervention. Thank you for this great case. All the best, Michelle and Alexander from the First Vienna Parasitology Passion Club. Christina.
Hawken writes, greetings from sunny Athens. The recent case involving the patient treated with what appears to be doxycycline for filariasis most likely represents Brugia malayi infection. While Brugia timori is a reasonable differential consideration, the geographical context strongly favors B. malayi as the causative agent. I appreciate the clinician's thoughtful approach, targeting the endosymbiotic Wolbachia bacteria before addressing the nematodes themselves and persisting with her clinical suspicion despite initial resistance. Her commitment to diagnostic thoroughness ultimately benefited both the patient and community. For your interest, I've included a link to documentation of a comparable case involving a native unnamed Brugia species in the United States that occasionally infects dogs and humans. Best.
Daniel.
Pietro writes, Dear TWiP team, greetings from Pavia, Italy. Shouldn't like every Italian email be read by you, Vincent, but I'll jump in on this one.
I'm half Italian too, I could. But my Italian accent is not as good as Vincent's.
Apparently I'm the only one here who doesn't,
Well, you got Pavia right, Daniel.
Yeah.
What is that?
You got Pavia right.
Pavia, okay. Regarding the case of the patient from Borneo with arm swelling while on treatment with eculizumab, my guess is filarial infection due to Brugia malayi. Eculizumab is associated with increased risk of infection due to encapsulated bacteria, particularly Neisseria meningitidis. Look at that. But I wonder if there's any association with the increased risk of filarial infection due to complement blockade. Similarly to W. bancrofti, infection, doxycycline may be effective in treating Brugia infection by killing endosymbiont bacteria Wolbachia. Thank you for your amazing podcast. Best wishes, Pietro.
So you mentioned this before, the eculizumab increases risk of gonorrhea?
So the issue is that the terminal complement is actually important in the immunology protection against Neisseria. Yeah. So this is like one of our board questions where someone has an issue with terminal complement, which is what you're kind of inducing iatrogenically with the eculizumab, and that would put a person at increased risk for Neisseria meningitis. Now, the interesting issue here is I wonder, if there's any issue with filaria, right? Because you've got this terminal complement, which actually creates these holes, and that's the way it induces killing. So is there any, is that just sort of some sort of an interesting random, that's how he came to this clinician's attention, or is there actually any connection there?
Okay, Anna writes, hello from the still rainy Pacific Northwest. My entry this week has a dual purpose. I must redeem myself for my incorrect guess of last episode's Parasite. My 12-year-old is sure I have brought eternal dishonor to our family name. So congratulations, I suppose. Your podcast empire is apparently more popular among middle schoolers than I thought. Or my middle schooler is just huge nerd. I'm leaning toward the latter, no offense. Yeah, so she was about to take some board, and I said, Anna, you got the case wrong. I wish you luck. For the unfortunate patient described, I have a few additional details I would like to know if possible. Well, no, we can't let you know because this is the episode where we're revealing it, Anna. But it's good that you asked the questions. 1, what is the eculizumab prescribed for? 2, what is the most recent CBC with differential, including RBC indices? 3, did the hospital in Kucheng perform a needle biopsy or an aspirate or an ultrasound of the infected limb? Now, knowing these details, knowing it is a parasite and not Wuchereria bancrofti, my guess is Brugia timori. Rationale: 1, unilateral lymphatic involvement typical of Brugia species. 2, endemic to Indonesia, but not known on Borneo. 3, no skin or pruritic lesions like Mancinella species. 4, responsive to antibiotics, likely doxycycline, due to symbiosis with Wolbachia. 5, Brugia has a commonly available dipstick antigen test. Only outlier was the negative nocturnal blood smears, but the patient's immunocompromised state or possible abnormal RBC indices may have influenced parasitic load or smear quality. Treat with 4 to 6 weeks of dox in non-pregnant adults and older children, then initiate a prophylaxis campaign with DEC, as well as mosquito mitigation strategies. I would love a book and will wait patiently. P.S. I did pass my CBIC test. Dr. Racaniello may rest easy. The only parasites I were asked about were Giardia, Toxoplasma, and American insurance companies.
I like that.
It's true, Anna. Oh, boy. Well,
she passed. That's good news.
Yeah.
I think I'm going to do 2. Maria writes, lymphatic filariasis, elephantiasis. Maria. Anne writes, greetings TWiP hosts. My guess for the person living in Borneo with left arm swelling is infection with Brugia malayi, the less common of the human filarial nematodes. I wonder if the blood smears may have been negative because as cited in Parasitic Disease in 7th edition, Brugia has a long pre-patent period. Treatment is directed at both the nematode, macrofilaria and microfilaria, and secondary microbial infections. I did not find any information about symbiont bacteria in Brugia species, unlike Wuchereria and Wolbachia. Brugia is a zoonosis always near and dear to my heart as a veterinary pathologist, and the reservoir hosts are non-human primates and felids. This is presumably why mass drug administration efforts are less effective in controlling Brugia as compared to Wuchereria, which is a primary human pathogen. And I agree, it is a small world. My estimation of a former mentor was raised considerably when he told me years ago that he met Dixon when he was at Notre Dame, and the most recent paper on African trypanosomiasis was co-authored by a co-worker. Still hoping to win a book for my daughter in med school. My best to you all, Anne.
Daniel.
All right. John writes, greetings, esteemed host. Still trying to win the book. I'm not sure if eculizumab affected anything, so I skipped ahead. The swollen limb made me think I knew what this was. Yay, but then the husband countered and I felt sunk. I looked up Borneo and found West Kalimantan had a parasitic survey on NIH listing Wuchereria bancrofti at 0.3% and Brugia Malay at 3.6%. So, that jogged my memory that it had more than one form. I took the opportunity to listen to the PWB lecture 28 to hear Dixon's history and Daniel's clinical side, and that reminded me of the interesting evolution of this nematode's nocturnal cycle in the host. The textbook also explained antigen tests are more sensitive than microscopy, which matches her experience here. In the textbook, treatment stated diethyl carbamazine, but I think this was reportedly unavailable. The antibacterial agent and length of time matches the next recommendation, doxycycline, 100 milligrams POBID for 6 weeks, and this patient saw improvement at 4 weeks. Prevention of lymphatic filarial Brugia Malay for the village may comprise of bed nets, screens, and perhaps spraying for these insects. However, in a rural area like described, I'm not sure if they have access and means to such measures. I love the varying difficulty of these cases. It keeps me on my toes, and I learn a lot. Cheers from John. So that's diethyl carbamazine.
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 Yep.
It's not even Italian, and I can't pronounce it.
It's not, yeah. Felix writes, greetings from the cloudy Greek island Kos. My guess for this case is Brugia malayi. The clinical description is suggestive for a form of lymphatic filariasis. Geographically, this parasite fits best. Treatment would then be dox targeting the Wolbachia. If there is no Loa present, ivermectin would be added. Oh, that's interesting. Maybe you can comment on that later, Daniel. Christina.
Leland writes, esteemed hosts, I would like to preface my guest with another tribute to Dr. Despommier. I knew him only through the various Microbe TV podcasts and the Parasite Without Borders parasitology lectures on YouTube, but I was always struck by his knowledge and his inquisitiveness, as well as his easygoing style. I know you mourn the loss of a colleague, mentor and friend, and so my thoughts and prayers are with you all, as well as my thanks for you providing a forum that introduced Dixon to the wider world. Concerning TWiP 255, the case of the swollen arm, it sent me to a deep dive into elephantiasis and filariasis, subjects that I rarely, i.e. essentially never, face in clinical ID practice in Alabama. When Dr. Griffin crossed Wuchereria bancrofti off the list, it left Brugia malayi or Brugia timori as other choices. Because Brugia timori is not endemic to Borneo, my diagnosis is filariasis due to Brugia malayi. The remainder of my refresher course was spent justifying the other elements in the history, assuming that Dr. Griffin had not perpetrated what Click and Cluck used to refer to as obfuscation and declarification. Diagnosis of Brugia infections, as with Wuchereria infections, is made by examining thick and thin blood smears for microfilaria, and the yield of these tests is highest when blood is obtained during the night due to periodicity of release of the microfilaria into circulation by the adult worms. There is also a dipstick test that is specific and relatively sensitive for Brugia infections, though the sensitivity of blood smears seems to be higher. This was the dipstick referred to in the case description. The antibacterial antibiotic used was undoubtedly doxycycline, which has no direct effect on Brugia. Instead, it targets the Wolbachia bacteria that live symbiotically with the worms and are absolutely necessary for reproductive fitness and other vital processes. Treatment with doxycycline kills the Wolbachia, which in turn leads to the demise of the adult worms and probably explains the improvement in arm swelling. 6 weeks of doxycycline may have been sufficient for a cure of the Brugia infection, though a single dose of diethyl carbamazine should also be given. The fact that the patient was on eculizumab was something of a puzzle to me. The literature did not have much on the role of complement in the modulation of the immune response to filarial infections, other than initial infection does lead to significant activation of the alternative complement pathways. Immune responses to established filarial infections seem to be modulated more by the Th2 pathway, and suppression of the immune response by the pathogens involves altering monocyte macrophage responses. I would note that eculizumab is used primarily for atypical hemolytic uremic syndrome, and I don't suppose that Dr. Griffin would be so diabolical as to have presented as a case where the arm swelling had nothing to do with a parasite and everything to do with some left arm complication of dialysis access. That having been said, I think eculizumab is probably more of a confounder than contributor to this infection. Thank you for an interesting case. I do hope I win. In the past, I would likely have declined the hardbook textbook as the free edition available for download serves me well. But since you mentioned that you have some triple-signed copies available, I realized that I would love to have a book with Dixon's actual signature as well as Vincent and Daniel's, of course. Regardless, I have thoroughly enjoyed the exercise, as always. Thank you for your excellent work.
Daniel.
Eyal writes, Dear Vincent and the sages of the eukaryotes, greetings from Sydney, Australia and the land down under, where the weather is warm and gray. Queensland is going through some major storm bashing and we are getting the dregs. I want to thank you for these amazing learning opportunities. Each case sends me down a rabbit hole, revealing a hidden dance of influence and complexity. I believe the patient is suffering from some form of filarial infection, causing lymphatic vessel dilation and inflammation. Doing some research, I found a lot of literature of treatment of the symbiotic Wolbachia in nematodes as a treatment method. Based on my understanding, once you treat the Wolbachia with antibiotics like doxycycline, due to the symbiotic relationship between the nematode and the bacteria, the nematode becomes sterile. over time reducing the filarial load and resolving the symptoms. This also serves in reducing the potential bacterial load and immune reaction when the nematodes die. My guest would Brugia Malayi and treatment with doxycycline. Thank you all for all the knowledge you share. All returning champion. You can always put that in your signature line because it sounds so exciting.
Sounds great.
Returning champion.
Freehoff writes, Dear professors, greetings from Caen, Normandy. Cayenne, I think, right? Where the weather changes every 15 minutes in Wuku area, bankruptcy is not endemic either. The man presenting with arm swelling probably suffers from elephantiasis caused by another filarial infection, namely Brugia Malayi. Getting rid of the endosymbiotic Wolbachia bacteria by administering DOX can be very effective in this case. There's even another filarial species endemic to Southeast Asia, Brugia timuri, which is found to infect people in the Lesser Sunda Islands of Indonesia, including Bali. Thank you for your amazing podcast. I'm already looking forward to the next month when another TWiP is parasitic. Yours, Friedhoff, proud owner of a signed copy of Parasitic Diseases. All right, there you go.
All right, we get two more guesses. I felt like you two seemed pretty confident, though, in your thoughts here. So, Christina, what were you thinking?
Well, I spent far too much time thinking about eculizumab. But I think actually the parasitic cause of the arm swelling is probably a Brugia infection. I did not come to a solution about the eculizumab, so it would be good if you tell us more about it, or if it was just a red herring.
All right, we can do that.
And actually, I would have liked now thinking back to when you presented the case, I had so many more questions that I really should have asked, but I didn't ask. But anyway, here we are.
Well, this mystery case, feel free to jump in with more questions this time. Vincent, what were you thinking?
So when you said arm swelling, I thought filariasis, and then when you said doxycycline, I said, well, it's one of these Wolbachia-containing parasites. Mm-hmm. And then you said it wasn't Wuchereria, so it's got to be Brugia Malayi. That's my thinking. Keep it simple.
All right, and that's what it was, and it looks like most of our people writing in got that, and a couple of the subtleties, I guess I'll go through. So one was, in a sense, the husband and wife. There was a little bit of a, as we often have in my household, a failure to communicate. Right, so the patient was not from Kucheng; it was actually from outside of Kucheng. So yeah, they do not have Brugia Malayi in Kucheng, but they do have it in some of the outside communities, right?
Can I just jump in there, Daniel? Because I've just read a paper today that there is actually increasing urban transmission because of Aedes obviously being an urbanized vector species. So potentially it could become present in Kucheng, the city. I thought that was really interesting. And actually it makes sense because Aedes does like kind of human environments and containers and, plant pots and stuff.
It's actually an excellent point, right? Because, if you think about and this story is perfect for this, Christina. So, here we've got the infectious disease specialist who's the head of the division there at this hospital, and he's not testing for it. So if it's present in the city of Kucheng, maybe what we should be saying, it's not being diagnosed in people who exclusively live in Kucheng, because it's kind of this circular argument where if you don't think about it and you don't test for it, you'll never get a positive test.
Like the STIs that you mentioned at the beginning.
Exactly. So I think that's actually a good point. So yeah, I will correct and say, so far it's not being diagnosed in people who live exclusively in Kucheng, but that could easily change. Mm-hmm. That could already have changed. And if we're not testing, if we're not doing serosurveys, et cetera, we may not find it. So maybe it was not a failure to communicate. And so, but I think what's also great here is not only is this gentleman benefiting, but because of the further investigation, his community is now benefiting because they actually identified a number of cases in that community. So now that you know that there's a problem, it can start to be addressed.
So the vector is Aedes aegypti?
So I think it's Aedes and Mansoni. I'm not sure which species of Aedes, but
Okay.
it's got multiple. Wuchereria has got 3 different kind of genera of mosquito that can transmit it, and Brugia, I think Aedes and Mansonia. Let me just have a quick look because I opened my lecture. Mansonia yeah, actually even Anopheles can in
Yes.
some instances transmit Brugia, and also Aedes. So.
What is the reservoir host? Is it humans or something else?
Well, someone said here it's a non-human primates, but I'm fairly certain it's primarily dogs and cats, or at least are an issue with transmission in the transmission cycle. I assume the non-human primates maybe don't live in such close proximity to people, but yet it is a zoonotic pathogen.
So Daniel, is treatment with docs sufficient, or do you need to do something else?
Yeah. So we'll wrap up this first, the vector, which I think is important. So this is, unlike, malaria, where we're really worried, where historically I'd always been worried about Anopheles and nighttime female biting. With the filarial worms, you're actually seeing a lot of Aedes, where, you're seeing daytime biting. So that the bed nets at night is not going to be as effective because you're getting bit during the day, and there actually are multiple Aedes species that can transmit it. So this can be a major issue with infection control, particularly as you're seeing here with the Brugia, where it's not just human to human, right? So you can't just go to a community, treat all the people, make it filarial free. You'd have to treat like every host. Now, let's go to treatment next, because that's the next is that. So as far as treatment, and this is the way I sort of remember in my head, is almost all of these worms are going to have the endosymbiont, the Wolbachia, except for Loa loa. Right. So you could think, well, I could just go ahead and I could treat with doxycycline. That should be fine. The doxycycline is not necessarily 100% effective. It's like some people, some of the studies would say a 96% reduction in the Wolbachia load. So, do you also treat with an antiparasitic as well as an anti-endosymbiont? So there are some studies where they actually do dual therapy, where you do the doxycycline and the ivermectin. And I think one of our writers actually sort of raised the concern about, how you have to be careful in a filarial Loa loa co-infection, where you want to actually get the filarial load down.
It was Felix.
Yeah, before you jump in, and that the particular threshold. There's some recent guidelines on filarial treatment, and they changed that threshold, but still the concept is the same. You want to get down that level. Now, the interesting, you're not necessarily going to be treating the macrofilaria with the ivermectin. You're going to be targeting the microfilaria. But if you target the macrofilaria with the endosymbiont treatment, you can potentially interrupt that life cycle, prevent microfilaria from being produced.
But Felix said that if there's no Loa loa present, then you can add ivermectin. So what's the problem with?
Oh, so if let's say you don't look at fortunately here we're not seeing like a huge level here, but if you treat someone who has the filaria and the Loa loa, there actually can be toxicity there. And there was a story that it was one of these organizations goes into an area, and this is right sort of in the western part of Africa, like right sort of in the area just sort of south of where it bends. And it's a community where, unbeknownst to them, there's a combination of Loa loa and filarial infection. They go ahead, and I think it may have actually been onchocerca and Loa loa. And so they don't check ahead of time, and you can actually end up having toxicity from the Loa loa. And it's actually the son of the chief of this village ends up getting the encephalopathy and ends up dying from the treatment without sort of doing this gradual reduction in filarial first. So,
okay. So do you know? I'm sorry, Christina, you had a question or comment.
I can't remember what it was, but I do have to make a correction. Mosquito species, genus is not Manzanella, of course, it's Mansonia. So just in case someone noticed that Manzanella is another species of Filarial nematode. Got that muddled up.
Manzanella perstans.
Yep.
Yeah. Which I've only seen one case of in my entire life.
I think we had one. Did we not have one?
I think that's probably the one that I shared.
Yeah, I think we did have one, yeah.
Daniel, what was the outcome of this case? Do you know?
As we sort of shared in the story, so not only did the patient do well with resolution of the arm swelling and sort of seeing, this was caught early before it became permanent, right? Because if you wait too long, it becomes permanent. But also the advantage of now they know that it was present in that community, and so they've started efforts to target that community. So
great,
Daniel. Shall we comment on the non-finding of microfilaria in the blood sample? Because I think that's quite interesting.
Yeah, I think that also goes to, you don't want to sort of just give up at that point. Because the antigen test has better sensitivity.
Is it an antigen test, Daniel? I thought the antigen test was only working with Wuchereria and the other one was an antibody.
It's correct. Yeah. It's an antibody test.
No, yeah. Okay. Yeah. I actually read, and I may actually remember not correctly, but I think the amount of microfilaria present in the blood is not necessarily related to the symptoms. So someone with filariasis symptoms may not necessarily have high filarial counts in the blood. So I don't know, is that something that it's just a vague kind of memory at the back of my head, Daniel? Is that something you remember?
Yeah, it's also described that the Brugia species have lower parasitemia, I will say, compared to the Wuchereria Bancrofti, where we tend to, so a couple things here which are interesting, right? So at one point I was going to spend some time in northern India studying tropical pulmonary eosinophilia. So there's this interesting thing with the filarial infections. And there tends to be during a certain period of the day, the microfilaria will actually really cluster in the tissue. So you're not really seeing it in the blood. But then there is this periodicity, and the periodicity actually, a person is in an area, we'll say India, and at night, every night you will see this parasitemia. So you want to do these blood draws, and actually concentrated blood draws at like midnight, 1 a.m. in the morning. That was sort of a downside to doing that study for me, actually. But yeah, because you have to do it.
And
then when the person changes, like let's say the person from that area comes to the US, once they've been here for a while, it actually starts to adjust. And the thought is this is some sort of an evolutionary thing that has to do with, you want to get bit by the mosquitoes, right? And the best time to have the microfilaria around apparently is when people are just laying there still being bitten by the vectors.
Wow, interesting.
But yeah, the Brugia tend to have a lower parasitemia. So sort of going that extra step.
You'd probably concentrate them through a filter or the knots technique anyway.
That's exactly, that's what's recommended.
We did that once. We did that in our DTMH lab. And one year, one of our students managed to explode one off.
Oh, wow.
And made a big mess. It was sheep blood, and it was a sheep filarial infection. So, there wasn't any imminent risk. And there was no vector either. But so we had to stop that experiment because
oh my gosh,
it was then considered to be too high risk in an undergraduate teaching lab.
All right. Time to give away a book. We had 11 eligible contributors today. So let's see what we have. 6 is the winner. Number 6 is Pietro from Pavia, Italy.
All right, we're going to need a phone number to mail this to Italy, or maybe you should just go over and visit, Vincent.
Yes, so Pietro, send us your address and phone number to twip@microbe.tv. And in the subject line, just write TWiP 257 book winner so we know what's going on there. Okay, TWiP at microbe.tv. Dan, do you have any more cases, or are you exhausted?
I have a new case. I'm glad we're not doing a hero, because I am going to have to go probably take some pain meds. I just had surgery earlier today for our listeners, and you have to wait to take pain meds. You can't be on pain meds while you're recording TWiP. So,
well, Daniel, you should be the hero, because coming on TWiP after surgery and in some pain, I think that is heroic.
Yeah, he was already a hero.
I can't miss an episode of TWiP. For the last hour, I've been distracted. So this has been quite good. But this is a fun case, and I will for those that have been listening since I joined. We did have this parasite on once before, so this is its second appearance. But we're still in Kucheng, Malaysia, in the northern part of the island of Borneo. And actually, there's some interesting features here that might, relate to some of the things we talked today. So this is the Sarawak portion of Malaysia. It's kind of two parts of Malaysia. There's eastern on the island of Borneo, and then a western, I'll say north of Singapore. And so here we have a man in his late 30s. He's admitted to the hospital in December. I'll suggest that the time of the year might matter. He comes in with daily fevers that last for several hours and shaking chills. He had previously been healthy, no medical problems. He lives in the city, he works in an office. However, in the few weeks prior to getting admitted, he was visiting the jungle. And apparently not too far outside of Kuching, one can go into the jungle and see orangutans. There's also these proboscis nosed monkeys or something you can go see as well.
That was going to be my question.
Yeah, you can see them as well. So he went into the jungle, but he did this like 2 weeks prior to any symptoms. So we're not really sure if this is related. But since then, he doesn't have any unusual exposures. He lives with his wife and children. Everyone else is healthy. But a few days prior to admission, he noted fevers, chills, headache. And now these fevers have been happening once a day. So every day he's having a fever. So daily fevers, and they last for several hours. He's a little nauseated, but he hasn't vomited. On exam, he has a fast heart rate. He appears ill. His respiratory rate is increased. He's not febrile like right when they first see him, but then he does later go on to have a fever. On exam, they're not able to appreciate an enlargement of the liver or the spleen. Otherwise, relatively unremarkable exam. His labs are notable for low white blood cells, anemia, and a platelet count of less than 50,000 per microliter. His coagulation studies are abnormal. His serum creatinine is elevated, and there is elevation of his serum aminotransferases. Okay, and I'm going to say he doesn't have dengue, by the way, just because I don't want to get people to And so, what parasite could this be?
Did he actually see any orangutans or proboscis monkeys?
So he did actually. Now, just for people who might be heading to this area, this is not the best time to see the animals, just because of the time of the year. There can be less sightings. You can actually go there, and for reasons that might be relevant to our case, you may not see them. But no, he's able to actually see orangutans and some of the other.
You say he has a wife and children. Did they go with him on this trip?
They went with him, but they were not always he went, in the evening, was sort of maybe spending a little more time. The wife and the kids spent a little more time in the lodge and other areas. But
so did you say that he was outside a bit more often in the evening?
He may have been a little more.
Did you have any other tests done? Because one notable test that I would probably do is not mentioned.
So what test would you think to do?
I would probably do a thin and a thick blood smear.
Okay. Yeah. So they did do a blood smear.
But he's not going to tell you the result, Christina.
That's an excellent thought.
Does he have HIV/AIDS?
He does not.
And when he was on this trip, did he eat anything weird?
No, he didn't. We didn't get any kind of unusual exotic exposures. Yeah.
Okay. I'm good.
Yeah, I'm good too.
Okay.
All right. That's TWiP 257. You can find the show notes at microbe.tv/TWiP. You could send your questions, guesses, comments, TWiP at microbe.tv. And if you enjoy these programs, we'd like to have your support to produce them, microbe.tv/contribute. Daniel Griffin is at Columbia University Irving Medical Center, parasiteswithoutborders.com. Thank you, Daniel.
Thank you. And everyone, be safe.
Christina Naula is at Glasgow University. Thank you, Christina.
Well, thank you, both of you. I had a really good time, as always. And I'm looking forward to a sunny weekend in Glasgow.
That's an oxymoron.
No, we've had 2 weeks of sun. So that's probably the last of the sun until December. But, I take it when I can.
I'm Vincent Racaniello. You can find me at microbe.tv. I'd like to thank the American Society for Microbiology for their support of TWiP and Ronald Jenkins for the music. You've been listening to This Week in Parasitism. Thanks for joining us. We'll be back soon.
Another TWiP is parasitic.